Welcome. In this video, we will discuss traumatic optic neuropathy, a serious condition affecting vision following head trauma. Traumatic optic neuropathy, or TON, is primarily caused by blunt or penetrating trauma to the head or orbit. Motor vehicle accidents, fall salts, and sports-related injuries are common culprits. The injury can be direct, affecting the optic nerve itself, or indirect, resulting from shock waves or bone fragments impacting the nerve. The pathophysiology of TON is complex. It often involves a combination of mechanisms. Primary injury can cause direct axonal shearing or laceration of the optic nerve fibers. Secondary injury occurs later and involves ischemia from vascular disruption, edema, inflammation, and the release of neurotoxic substances. These secondary events further damage the optic nerve, potentially leading to irreversible vision loss. The optic nerve is particularly vulnerable as it passes through the optic canal, where it can be compressed or contused. Epidemiological data reveals that TON occurs in approximate 0.5% of patients with closed head injuries. The incidence varies depending on the severity of the head trauma. Males are more frequently affected than females, and younger adults are at higher risk due to their greater participation in activities associated with head trauma. The signs and symptoms of TON vary in severity. The most common symptom is sudden, painless vision loss in one or both eyes. Other symptoms may include decreased visual acuity, visual field defects, abnormal pupillary responses, such as a relative afferent pupillary effect, or RAD-AP, and impaired color vision. In some cases, patients may experience eye pain or headache, especially if there are associated injuries. Diagnosing TON requires a thorough ophthalmological and neurological examination. Visual acuity testing, visual field assessment, and pupillary examination are essential. Optical coherence tomography, or OCT, can help evaluate the retinal nerve fiber layer thickness, providing objective evidence of nerve damage. Neuroimaging studies, such as CT and MRI scans, are crucial to rule out other causes of vision loss, such as optic nerve compression or hemorrhage, and to assess the extent of the head injury. While there aren't strictly defined types of TON, it's useful to think about it in terms of the mechanism of injury. Direct TON refers to cases where the optic nerve is directly damaged by penetrating trauma or bone fragments. Indirect TON describes cases where the nerve is damaged due to shock waves or compression, without direct physical disruption. The severity of the injury also plays a role, ranging from mild, with some recovery possible, to severe, with profound and permanent vision loss. Treatment and management of TON remain controversial. High-dose corticosteroids are often administered, but their effectiveness is debated. Optic nerve decompression surgery may be considered in cases where imaging shows optic nerve compression. Supportive care, including monitoring for intracranial pressure and managing other associated injuries, is also important. Visual rehabilitation may be helpful for patients with permanent vision loss. Preventing TON involves minimizing the risk of head trauma, wearing appropriate protective gear during sports and recreational activities, using seatbelts in vehicles, and preventing falls in the elderly can all help reduce the incidence of TON. The prognosis for TON varies widely. Some patients experience spontaneous recovery of vision, while others suffer permanent vision loss. Factors influencing the prognosis include the severity of the initial injury, the time to treatment, and the presence of other associated injuries. Recent research focuses on neuroprotective strategies and regenerative therapies to improve outcomes for patients with TON. For example, studies are investigating the potential of stem cell therapy and gene therapy to promote optic nerve regeneration and restore vision.